Welcome back to Diabetic Foot Files. So, I mean, I can spread this out. Definitely going to deep dive into it, but the answer is no. Simple as that. The answer is no. Can I drive on it? No. And we're going to figure out why I said no, but the answer is no. You're not going to drive with the post-op shoe. You're not going to drive with the cam boot. That's pretty much illegal. Just don't drive on the diabetic foot ulcer. You cannot drive with the diabetic foot ulcer. I understand the independence. I try my best to keep it and compromise, but that's something I will not compromise on or agree upon driving with the diabetic foot ulcer. I don't think that is the appropriate approach, and you're going to figure out why today. So, I understand. Patients will come in and say, "Doc, it's a small ulcer. I can drive on it. I get it. I get it that there's nobody else who can drive me. I get it. I get it." I don't know how to get around that aspect when there's nobody and you're trying your best to follow up, but you cannot drive with the post-op shoe. You cannot drive with a cam boot. You cannot drive barefoot. You're not supposed to, and you have to understand that driving isn't passive. Driving is actually repetitive trauma, pressure cycling, shear force, neuromuscular demand, all directed through the exact structure that is already flailing. So, today we're going to break down why driving with a diabetic ulcer is dangerous, biomechanics of the right foot, what happens with and without a shoe, and most importantly, what patients can do instead. And we'll do our best to find a better compromise for you. The better thing is that there should be health related transportation services for patients so that they can go to their appointments, get picked up and go to their appointment, especially if they do not have the support system like family, children, friends to take them to and from their appointments. So, with the core problem, I said problem, but forgive me, problem, the core problem of a diabetic foot ulcer is not just the wound. Remember, we're talking about mechanical failure, breakdown, tissue breakdown at a certain point. So, a mechanical failure, a vascular compromise, okay, so more pressure you're putting on, more vascular compromise you're putting on that foot as well. And the foot is also neurologically disconnected as well, right, because of the neuropathy. So now we're combining it with driving. And driving requires constant ankle plantar flexion and dorsiflexion, which is like moving up and down, repetitive forefoot loading, sustained pressure on the metatarsals, and rapid force generation because you're braking. You have to brake. So this literally is a perfect storm for the deterioration of your ulcer. So let's just go through the biomechanics of pressing the pedal. So the movement pattern is you drive with your right foot. That involves the heel pivot fixed on the floor. So your heel pressured on the floor as a pivot, right? As a leverage. And then there's movement through the ankle joint and the subtalar joint. And then the pressure shifts from the heel to the midfoot to the forefoot to the toes. So when we press the gas pedal, that's for acceleration, correct? So sustain from low to moderate plantar flexion. And this causes continuous pressure on the first and second metatarsal heads. And this causes a micro trauma pattern. So constant ischemia, tissue compression, and this causes chronic pressure loading. So the brake pedal, which is the emergency, we press the brake pedal on and off now and then, right? So it requires rapid, forceful plantar flexion, and that increases the ground reactive forces on that foot and peak pressure spikes. So this can cause acute trauma on the compromised tissue as is. And then the repetition of the trauma. So driving requires hundreds of micro movements per trip. So this means repeated shear and pressure cycles, delayed healing, and tissue breakdown acceleration. So what happens to the ulcer? So we already know mechanical consequences of putting pressure on an ulcer is increased shear stress, increased pressure necrosis, wound edge breakdown. So the wound edges are trying to come close together and it's breaking down because of the repetitive trauma, and the callus reformation around the ulcer can accumulate faster than it would if you were staying off of the ulcer. What are the biological consequences of this? Reduced perfusion during the compression, hypoxia to the wound bed, impaired fibroblast activity, and delayed granulation. And what do we want for the wound to heal? We need granulation. We need that proliferative phase 3. So in clinical reality, if you're driving on a small ulcer, it becomes a deeper ulcer eventually, and it can become a tunneling wound and a potential abscess. And eventually, the longer a wound stays open, the higher risk of osteomyelitis. And the higher risk of osteomyelitis, the higher the risk of amputation. So I have patients that, uh, we all try our best to, like I said, to maintain the independence, understand. I love when my patients tell me the truth. I appreciate it. But the whole point of telling the truth so that we can redirect you to make the better decisions to get this wound to close and for us to help you keep your foot, but also help keep your independence. It's kind of like when it comes to wound healing, it's kind of like a delayed gratification system. I get it. We want to still walk on it because we don't feel anything. We already have a doctor looking on it and everything like that. We already have a protective shoe, but you're still supposed to try to stay off of it and not drive with it. Okay. So, what's the whole point of having the post-op shoe or the post-offloading shoe or even a cam boot, and definitely not with a total contact cast? You should not even consider driving if you have a total contact cast. You shouldn't consider driving if you have a cam boot. You shouldn't, okay? I know patients were moving and they'll be like, "Oh, I did it barefoot. I did it with just the dressing on." And I'm like, "No, you're not supposed to. That's not legal either." Okay? So, with post-op shoe, what is the post-op shoe supposed to do, or the surgical shoe or the offloading diabetic shoe? It is supposed to redistribute the pressures, right? And it is externally protecting the diabetic foot ulcers. What the shoe will possibly increase localized pressure points can compress the dressing, okay? That's a possibility, and trap in moisture. I notice patients do have more moisture in their foot the longer they stay in a protective external protection like a post-op shoe or a cam boot. I think it's because they put more pressure on their foot with it, okay? And also look out if the shoe is too tight, if the dressing is too bulky, and no removing of the post-op shoe, but I just know the reality of the situation a lot of patients do. So, when it comes to the biomechanics while driving with a post-op shoe, you shouldn't, okay? Disclaimer, don't do it. But the rocker sole interferes with the smooth pedal control, and then there is reduced ankle proprioception, and it alters the force of the transmission. So what can go wrong? Delayed reaction time. When you're wearing a post-op shoe or any offloading device while you're trying to drive, you have delayed reaction time. That means you cannot feel the pedal normally. And this gives a slower transition from gas to brake. And this can increase your risk of having a car accident. Then there is unstable contact. The shoe doesn't fit or sit flat on the pedal. It doesn't. It wasn't designed. Post-op shoes, cam boots, any offloading device for your diabetic foot ulcer is not designed for it to sit on a driving car pedal. No, it's for you to stay off of it, and if you have the partial weight bear. Okay, but rocky motion causes slipping and misapplication on the pedals. Increase shear inside the shoe, so the foot can slide with the shoe on, the dressing can get disrupted. I've noticed that whenever I see a nice dressing and it completely is obliterated and switches to exactly one side, I definitely can tell, yes, you have been on this. And I asked, "What were you doing?" The dressing got completely disrupted, and the wound dressing that's supposed to be on the wound bed is completely off the wound bed because of the disruption, the gravitational forces and disruption. And wound edges experience friction, and we need the wound edges to come together, not to be further apart for the wound to close. So patients may think in clinical reality, I'm wearing a shoe, I'm protected. But no, you're actually increasing the risk of being in a possible car accident, and that's not what we want. You're compromising the offloading that is supposed to benefit you, and the ulcer is still under stress. So you can see it doesn't benefit the patient or the ulcer in any shape and form. So, we already know that driving with a cab boot, that's illegal. You shouldn't be. In my opinion, that's illegal. I'm not sure, but it is. It shouldn't be. You're not supposed to, okay? Like I said, it compromises your reaction time when it comes to driving. But some patients try to do it, and patients here, you shouldn't do it. Honestly, when you have a diabetic foot ulcer and the patient is a driver, you have to explain to them that they cannot drive with that foot. You cannot drive on that foot, okay? It's your right foot. You shouldn't drive with it, okay? You need to make arrangements with somebody or get a transportation services. And the other thing is, we could possibly even sign a consent saying that you are fully aware that you're not supposed to drive with this post-op shoe, this cam boot, or with this diabetic ulcer, and so that you can legally protect the patient and yourself, saying that the patient is aware of the consequences because you shouldn't be driving with a post-op shoe on your right foot. You shouldn't be driving. It puts you at risk. It puts other patients at risk. It puts your ulcer at risk. Okay. And everybody knows the cam boot is quite heavy. So the cam boot controls the ankle mobility. We need our ankle to plantar flexion and dorsiflexion. And I that's completely impossible to do with a cam boot. So you won't be responsive. It blocks that movement. Okay. That's the whole point of a cam boot, controlled ankle motion, right? I believe so. It controls ankle motion. Okay. And then what else? The bulky structure of it. It's heavy. Like I said, the hard shell reduces the pedal feel. You can't feel the pedal, and it increases the risk of hitting both pedals at the same time and not braking fully. And like I said, you will have a delayed reaction response, a delayed emergency response. In a situation, you're going to need like millisecond level reaction, and a cam boot mechanically delays that. So bottom line, you're not supposed to be in it while you're driving. You're not supposed to be using a cam boot while driving. Okay, it's completely unsafe. It's legally, I think it's illegal. It's legally questionable and clinically discouraged. So, what is the big mistake I notice patients do make when it comes to driving? And you're not supposed to, yet again, but they will wear the boot to the appointment and then they will take it off to drive and then walk without it to the destination. And that completely defeats the purpose of the treatment of us offloading the ulcer. Then other patients will be like, okay, well, I won't wear the shoe at all, right? Shoe means less pressure. You're wrong. The reality is you're just putting more direct force on the ulcer. There's no shock absorption, and there is a even more increased risk of shear forces, or friction, and skin tearing. So it's often worse than wearing the shoe when you're not wearing the shoe. And the worst case scenario is the patient driving barefoot, right? With neuropathy, there's no pain feedback, there's no pressure awareness, and there's maximum tissue damage. And like we know, neuropathy is silent, okay? That's the one of the biggest villains when it comes to our diabetic foot ulcer. You cannot control or feel the pressure, you cannot control or feel the heat, you cannot feel the trauma. So the heightened risk of a overuse injury as well, right? You putting more pressure on that, but you possibly can ignore the injury progression. A lot of patients do not feel when their ulcer is getting bigger. I always have to ask, were you on your feet lately? They'll be like, yeah, I had a family event, things like that, and they will continue to driving. But by the time that we notice something, it's already severe. Okay. So safety risk beyond the foot, okay? Driving with your foot ulcer also affects, like I said, it increase your risk of having an accident, okay? It alters your foot positioning, the compensatory movement patterns, and like we said, increased risk of pedal misapplication and loss of control. When should patients not drive? If you have a plantar ulcer, especially on the forefoot, if you have an active infection, if you have post debridement, that just make you bleed even more as well. Post surgery, absolutely not. Severe neuropathy and ulcer, and wearing an offloading shoe or boot, and you should not remove it, okay? Because and so we're going to talk about the alternatives. Alternatives are key to help us get to and from our appointment and the transportation support that we need. Family assistance, taxi, Uber, community transportation services, medical transport services that are designed to help you get to your wound care dressing changes, your wound care visits, mobility offloading like a wheelchair, crutches, knee scooter reduces total foot load. And I'm not even going to mention left foot driving. Sometimes they make vehicle modifications where you can control the car only by hand. That's in advanced cases. And then also there's the option of doing telemedicine visits, but that is very hard to do when you have wound care. You need a wound care nurse, okay, to come to your home if you have to do a telemedicine visit so that we can see the wound, okay? But what can we do as a clinician to help change the outcomes of patients' compliance of not driving on their diabetic foot ulcer? Clearly, just educate the patient of the risk of the wound and their foot and a possible car accident with driving. Try not to drive on it. You cannot say that try because when people try, that means they're not going to. In my opinion, I hate when people say I'm going to try to do it. That means no. I don't like to hear somebody say you're going. I'm going to try. No, you're not going to do it because if you wanted to do it, you would do it. So just say driving is actively worsening your wound every time you press the pedal on it. We document it, okay, because the patient will be on driving restrictions, patient education provided, and then give a plan, not just a warning, okay, and how we can reinforce it. And the best thing as a patient, just be honest and realistic with what your daily demands are when it comes to you trying to maintain your independence. And as a physician, as your wound care doctor or healthcare professional, we can come up with a really good treatment plan to make the best of both worlds, where we get it healed and continue to maintain your independence. Okay. So, in the reality check, let's be blunt. Many amputations do not start with infection or trauma. It usually starts when a patient keeps walking on it or I had to get around, okay? So in conclusion, driving on a diabetic foot ulcer is not harmless. It is not neutral and is not necessary. In most cases, I get it. I get it. Maintain independence, you need transportation, but we have to figure it out because there's no point of you constantly putting repetitive trauma on the wound, constantly causing mechanical breakdown, delaying the healing, just to come to a wound dressing where it's just getting bigger because you won't stay off of it and you keep driving on it. We have to find an alternative where somebody can drive you, medical transport services, friends, Uber, things like that. We can work around it because we already know repetitive trauma, mechanical loss, delayed in healing is the beginning of limb loss. Okay. If your foot is trying to heal, why would you put it back under the pressure every time just to leave the driveway? Okay. And I think we'll eventually get into also disability plaques as well. That's an option too for your family relatives. That is a benefit that they can use your disability plaque, right? They can be the driver for you and they get the disability plaque because they're driving you and they can park so that there's less of a walkway time between you and the storefront or wherever you need to go. Okay, so that is a benefit for somebody or a family relative or a friend to drive you. They would be your personalized driver and they would get the disability plaque to be able to drive you. Okay. So that's another option. So I hope patients like this episode because we try our best as healthcare providers, especially for our wound care patients, to help you maintain the independence. I completely understand. The whole point is to increase the quality of care of your life and maintain the independence. But if you're going to consistently do something that does not benefit the ulcer or you in any shape or form, it doesn't make sense, okay? So this is Diabetic Foot Files, where we're trying to heal and tell the truth and take care of your feet because they take care of you.